Okay, so this video will be the shortest of the point of care ultrasound videos. We're going to go over performing a basic IVC ultrasound and how we can utilize that in our sick patients. So for this one, we're going to want to do phased array or curvilinear. IVC obviously is deep, so we want one of the low frequency probes. If you were doing this on a child, you could maybe get away with that linear probe. One caveat when we're doing our IVC assessment, there is definitely some debate about where to assess, whether we're looking just below the liver, whether we're looking a little bit further down. Some people will use the superior vena cava as well. I'm not really going to weigh in on that other than to say that there's lots of debates about its utility and what it means. And so we have to be very cautious in how we're the interpretation is very simple as far as whether it's collapsing or not and what's abnormal and what's not, but we have to be very careful about how we incorporate that in and what the evidence says. So there's no great evidence that IVC is a great indicator that your patient will respond favorably to fluids, but IVC as a standalone is a decent predictor of a person who would who could tolerate our fluids, or what we call fluid tolerance. And if you use that in tandem with a cardiac ultrasound, that can improve the sensitivity of the test fairly well. As pretty much any diagnostic on the planet, as a standalone, they don't always work out great, but when used in concert with a good physical exam and history, the specificity and sensitivity goes up. So you just have to be careful about how we're incorporating this, but the image acquisition is fairly easy on this one, especially compared to, say, a cardiac assessment. So when you get good, you can skip this step, but until you're certain about what you're looking at, this is a good starting point. Also, this will be a good starting point if you want to look at the aorta and inspect for abdominal or descending aortic aneurysm or dissection. So this will be your starting point for that as well, and I'll cover that in a different video later on. And so what you're looking for, the first thing we want to do is we want to find the abdominal IVC, and we're finding it kind of halfway between the xiphoid process and the belly button. That probe actually is a little bit high for to get the image that you see there, but it's not too far off. And what you're looking for is basically Cookie Monster. You're looking for two eyes and a mouth. Those two eyes are your IVC and your aorta, and then the mouth is the vertebral shadow. And it kind of makes that open mouth face looks like a Muppet to me. And so you're just looking for the Cookie Monster face, and then if you're uncertain whether you have the IVC or the aorta, two things to think about. First off, always be aware of where your probe is and your probe marker. So again, the probe is going to go right where you would do the Heimlich maneuver. You want a transverse view just like you see on the screen, so the probe marker needs to either go to the patient's left or right side. I always throw it on the patient's right side. And then the IVC should run along the patient's right side. If you're still not sure, you can push down and one of the eyeballs will collapse or wink at you. Again, if the patient has high venous pressures, so they have an elevated central venous pressure secondary to pulmonary embolism or cardiogenic shock or heart failure, etc., fluid overload, that compressibility will be less noticeable than in a person who has a who might be in a hypovolemic or vasodilatory type state. But those are your things. Once you locate the IVC, you want to center it over the image, and then you are going to rotate your probe 90 degrees so that it is now longitudinal with the probe marker pointed towards the patient's head, again, or feet. You would get the same image. It's important that you learn one way so that you don't confuse yourself or misinterpret, but again, this one's pretty straightforward and easy. So I rotate the probe, and when I rotate that probe, that circle is going to turn into a bar, and so you should see the IVC beneath you. Again, if the patient's hypovolemic or vasodilated, or you have, for whatever reason, has a very collapsible IVC, if you put too much pressure, you can actually cause it to collapse, which will keep it out of view. So be cognizant of how much pressure you're actually putting down. This is also a very easy image to get in a patient who doesn't have a lot of belly fat, but in a person who's morbidly obese, this is going to be a very difficult assessment to find in that mid-abdominal region. And so you may find yourself skipping that step and going straight to where we're at now. So once you get the IVC centered and you've rotated 90 degrees, you're going to drift the probe up just a little, and then you're going to notice the provider's hand there, it moves downward. And what you're doing is you are shooting the beam under the xiphoid process. So you're going to drift up until you see some artifact. That artifact would be the xiphoid process. You can back off just a little bit, and you're going to now push in. You're going to push down towards the patient's spine, and then you are going to pull that probe and angle it the beam towards the patient's head, just like you see there. So that would cause you as the provider to actually kind of bend your hand down a little bit and shoot the beam up under. And when you do that, you're going to see three things come into view. You should see the IVC, you should see the liver, and you should see the right atrium and the heart itself. You will see the contraction and the motion artifact occurring. And so what this is giving you is this giving you an assessment of preload. This is showing you right ventricular preload. It is showing you the blood entering the right side of the heart, and that's an invaluable tool. Again, the only other way that we measure this often requires invasive means, which the insertion of a pulmonary arterial catheter and transducing the line to get, or a triple lumen catheter and transversing the distal tip if it's placed in a subclavian or internal jugular location, you can get a central venous pressure that way. This is actually showing you a visual representation. You can use this to get a quantitative measurement of your central venous pressure, but again, that's not what I think is the utility for a point of care ultrasound. We're looking for major qualitative assessment, and so what I want to know is do I have a big IVC, do I have a small IVC, is it collapsing, and that. So let's zoom in on one here. So here's a patient. You can see your IVC. Again, the image is flipped. This is one where when you're picking your pre-select, it kind of depends on what you're doing. So an IVC assessment will often follow a cardiac assessment. And so if you're kind of in a hurry, if you're trying to do this rapidly, you may just leave it in the presetting, depending on the ultrasound device you're using. And so this is a cardiac. This probe was left in a cardiac preset, but again, you can still clearly see what you need to see there. So your liver is up top. You can see it's moving back and forth with the patient's spontaneous breathing, and you can see the IVC, which if you were to measure that out, normal IVC somewhere around 2.5 centimeters in diameter if you're measuring from the outside of both walls. And the evidence will say that a collapsibility, so you can actually notice it's collapsing just a little bit with spontaneous breath. If you had the patient breathe in sharply, a normal finding, so what we call like a sniffing maneuver, you would expect to see the IVC collapse by about 50% or so. So if the IVC did not collapse by that much, that would be predictive of a distended IVC, or if it was greater than a certain measurement. And if it collapsed by more than that, that would tell you that your CVP is, on the low, either on the low end of normal or low. But again, how do I use this for a quick assessment? Is basically you want to look at it and you want to see, is it normal size or not? And I do mean that visually. So does it look normal in size? And you can kind of gauge. You have your depth gauges on the left there. It goes down right. The inferior part of that is 15 centimeters. So you can gauge a qualitative assessment of how big that IVC is, and then just, is it collapsing on you or not? And so if you use that in tandem with the cardiac assessment, that can tell us some things. So if I did my cardiac assessment and I saw a poor ventricular contraction, and then I saw an IVC that was not collapsing, and a patient who is hypotensive, that's much more pushing us towards some sort of cardiogenic type shock state, and that maybe inotropic therapy is indicated, versus if I saw a hyperdynamic heart with a spontaneously collapsing IVC, that would tell me even more so that I might be dealing with hypovolemic or vasodilatory shock. And even in the absence of its predictability of the cause of the shock, it fairly accurately can at least tell you that the patient could tolerate a fluid bolus and that it is safe and reasonable to trial that. So rather than getting in the weeds about using it as a diagnostic tool to determine the actual disease process, that's not really what we care about in the sick crashing patient. What I care about is I want to stabilize this patient. What information do I have and what can I use it for? And so if you have a collapsing IVC and a hyperdynamic heart, that is certainly a reasonable decision to give that patient fluids, compared to if you have a patient with poor cardiac wall motion, poor ejection fraction, poor systolic function, and non-collapsing IVC. That's more so to maybe tell you, let's skip the fluids, let's try an inotropic drug. Or maybe perhaps I see a dilated right ventricle that's compressing into the left ventricle, and a non-collapsing IVC. That might key me in that I have perhaps a pulmonary embolism. And so here's an example of a collapsing IVC. So again, without even looking at many IVCs, maybe you're a novice, you've never even touched an ultrasound, you can look at that and you can see the IVC is small, and then on spontaneous breaths, it is completely collapsing. This patient's not doing a sniffing maneuver. This is just spontaneous breaths that are causing the walls to collapse. You can see the heart beating, and you can tell that my heart rate is very high. On cardiac assessment, this patient also had hyperdynamic wall motion, and so that keyed us in that that's a clue in that the patient would be fluid tolerant. Patient received fluid bolus and improved considerably. In a patient, in this particular case, a patient that had pre-existing heart failure as well. So that's where it can help to guide our resuscitation a little bit. Okay, so like I said, short video. In summary, it's a very quick and easy question to ask. It's an easy view to get. If they are morbidly obese, you may have to skip that first step and just shoot up under the xiphoid process. Make sure that you are looking at the IVC. That's the only fail point from the skill side of it, is you need to make sure that you are looking at the IVC and not the aorta. So if you're not sure, is it pulsating, that would clue you in that you might be looking at the aorta. You can throw color flow on there and try to help as well. But once you get that IVC in view, you're asking a simple question: is it collapsing or not on spontaneous breaths? I did forget to mention, if the patient's mechanically ventilated, the physics would flip, so the IVC would actually get bigger during the breath in and smaller as the breath out. But it really honestly doesn't matter, because you're just looking at overall change in size, and that's going to be present either way. A lot of the studies were done on mechanically ventilated patients, so some of that IVC collapsibility criticism comes from that fact as well. But in the back of an ambulance or in the ED, rapid assessment, shocky patient, is it collapsing, is it not? And then using that in tandem, ideally with a cardiac and pulmonary ultrasound, to help confirm my diagnosis, or at least, if nothing else, guide the therapy that we're providing, whether we're going to continue to give intravenous fluids to a patient or initiate inotropic therapy. If you have a collapsing IVC and I have a hyperdynamic heart, that's a patient that can, and especially if I had to do a pulmonary assessment and I don't see B lines, that even more so indicates that that's a safe patient to give IV crystalloid fluids to them. If I do see B lines, if I see poor cardiac wall motion, and I see a distended or non-collapsing IVC, maybe we need to reevaluate, think about what's going on, and consider inotropic therapy to help stabilize the patient. Okay, thanks guys.